Right now, today, prescription drugs in this country kill more people per year than car accidents. One thing that's very interesting is driving a car is a very dangerous experience. It is life-threatening, and yet somehow the numbers of people that are being hurt or killed from prescription drug overdoses, a large percentage of which is controlled substances, those numbers are climbing above the car accident numbers is because it's such an epidemic in our country. Another reason is that actually the numbers of deaths and injury from car accidents is declining. Why is that? Technology, right? Technology, safety measures, regulation. And so a lot of those same themes, that's what we're here to talk about today.
This is a really complex issue, running all the way from writing the prescription to receiving the prescription, then checking on the PMP. When you think about authentication as authenticating the user, you want to make it as easy as possible. To give you an idea of the complexities of opioid prescribing, I write it in my office or with the patient. It's printing on a secured printer on special blue paper that can't be photocopied and can't be anything else, so that the patient can get it. So if they're in the office, that's not so horrible. I can go down the hall and get it and hand it to them. Okay? But if they're not in the office, a renewal of medication or something, they've got to come and get it, or we have to mail it to them. And then if we mail it and they say they didn't get it, then you have this judgment question is, do I rewrite it? What happens with that other prescription if I rewrite the first prescription? If you think about that as a crazy scenario, right? I'm handing my prescription with my signature and my DEA number to anybody who wants it for public consumption, or we can find an electronic way to do that. And so we have just started using Imprivata's single sign-on, but also their dual authentication program with fingerprint authentication to do prescribing electronically.
2 years ago, the law required all pharmacists in Massachusetts to be trained in using the prescription monitoring program. They weren't required to use it, but they were required to know how to use it. Right now, there shouldn't be any obstacles for pharmacists to use the PMP, and we have noticed that there have been an increase of pharmacists signing up for the PMP, so I think we've made a lot of strides in the past couple of years.
This is a very complex sequence of workflows that you're going to add to both my IT staff, but even more importantly, for every clinician that now needs to do electronic prescribing. The DEA really took a much more of a forensic approach to say, I really want to have digital integrity of that script all the way from the point it was issued, all the way through the routing, through the SureScript hub, right down to the pharmacy. So there's accountability of this script that used to be a piece of paper. Now we're substituting it in an electronic fashion. There are specific identity proofing methodologies that you can either have your institution vet out the identity of the prescribers, or if you're an independent provider, you have to go to something called a credential service provider and have them verify all your credentials. Once you've done that, the system then has to be ready for access control, where your IT administrator now has to add you into that system, into the EHR system, to actually allow you to prescribe.
Adoption has been very slow. Right now it's probably 400,000 prescriptions for controlled substances a month. When you think that we do 130,000 prescriptions an hour, that gives you a sense of the difference in the scope here. Our experience is there's still a lot of misinformation out there in the provider community. Is it legal? Is my EHR certified? What does it mean for my EHR to be certified? How do I do this? So there's a lot there's a lack of information.
I actually think the management of the reports, especially in the rollout, is a real challenge because you get a lot more failures early on. People have to learn, how to use the fingerprint reader. You got to put your finger on for a reasonable period of time. You got to put it in the right place. All that, it works. All the technology works.
Well over 90% of physicians are using electronic prescribing today. It is true that you have to go through somewhat onerous one-time authentication, identity proofing and authentication with the credentialing, whether it's a biometric or whatever else, but it is not that physicians are technophobes. This does improve workflow.
We're actively involved in this on many levels, everything from the federal level to various different states, certainly in New York. And I guess one of the main reasons we want to bring this before you is this issue of education and just getting the dialogue going. And we see this nationally as a time where everything is just on the path and the growth curve is exponential right now. And getting it right in this difference between good technology and bad technology, being adopted and accepted and saving lives and helping people versus causing barriers and lack of adoption and lack of credibility yet again for providers having something foisted upon them that is not good. The stakes are high.
How do you make that experience as easy as possible, similar to driving a car, where the safety is built into the system and users can focus on the driving experience? We've tried very, very hard working with a lot of different organizations to streamline that to the extent that it becomes a very simple process.